Managing fibromyalgia requires addressing a complex pathology of widespread nociception, chronic fatigue, and the profound effects of central sensitization. Current guidelines from the European League Against Rheumatism, or EULAR, establish aerobic and mixed exercise as the primary cornerstone of non-pharmacological treatment. This creates a direct clinical paradox. The recommended treatment requires continuous movement, but the disease's primary symptom, hyperalgesia, often makes that movement intolerable for the patient. Physical modalities serve as mechanistic adjuvants to bridge this gap, facilitating movement by targeting the biological barriers to activity. Effective long-term management depends on selecting non-pharmacological interventions that can measurably modulate a patient's underlying neurobiology. Modern physical medicine defines these modalities as precise applications of applied physics. This diagram categorizes treatments into 5 energy vectors. Thermal and sound energies on the left use mechanical forces to manipulate blood flow and tissue extensibility. On the right, electrical, magnetic, and radiant fields are used to influence cellular activity and modify nerve excitability. Optimizing clinical outcomes requires evaluating the evidence for how each specific energy vector modulates pain at either the peripheral or central level. Within the electrical branch, transcutaneous electrical nerve stimulation, or TENS, is the most frequently studied peripheral intervention. TENS targets the peripheral nervous system by activating pain gate mechanisms, intercepting nociceptive signaling before the data reaches the central nervous system. The Fibromyalgia Activity Study with TENS, or FAST trial, utilized a modulated frequency between 2 and 125 Hz, applied at the highest intensity the patient could tolerate for 2 hours a day. Findings from the FAST study show the active TENS group achieved significant reduction in movement-evoked pain compared to the stagnant placebo and no treatment groups. Secondary analysis showed patients with higher baseline pain sensitivity achieved the greatest clinical improvement using the active device. Trial data indicates a robust safety profile, with a number needed to treat for pain and fatigue of 3.3 and 5.3, respectively. These results suggest TENS is an effective tool for suppressing movement-evoked pain, creating a window for patients to engage with exercise-based rehabilitation. For centralized pain, the taxonomy shifts to magnetic energy through repetitive transcranial magnetic stimulation, or RTMS, and central electrical energy via transcranial direct current stimulation, or TDCS. These techniques use non-invasive fields to bypass peripheral nerves and directly modify cortical excitability within the brain. Clinical protocols generally target 2 specific zones, the primary motor cortex and the dorsolateral prefrontal cortex. In multiple randomized controlled trials, high-frequency RTMS and a nodal TDCS applied to the motor cortex have consistently outperformed sham treatments. This data shows active stimulation driving a measurable decrease in scores on the Fibromyalgia Impact Questionnaire and the Visual Analog Scale for Pain over a 4-week period. Research using proton magnetic resonance spectroscopy provides a biological basis for these clinical improvements. Patients receiving active TDCS demonstrate significantly lower levels of glutamate and glutamine within the anterior cingulate cortex compared to those receiving sham stimulation. These precise shifts in neurochemistry indicate that magnetic and electrical stimulation can quantifiably alter the brain's centralized pain processing. Radiant energy modalities focus on photobiomodulation therapy, often referred to as low-level laser therapy. Rather than heating tissue, photobiomodulation relies on the direct absorption of photons by receptors on the nerve cell membrane. This absorption increases the porosity of the membrane, specifically affecting the mechanics of the sodium-potassium pump. The therapy triggers a cascade where potassium ions are expelled and sodium ions are reabsorbed, rebalancing the electrical charge across the membrane. This rebalance prevents the nerve from reaching its firing threshold, effectively blocking the transmission of the pain signal. This mechanism of postsynaptic inhibition resembles the action of opioid medications, though the effect is achieved locally without systemic pharmacological interaction. Multiple trials validate this local blockade, showing a measurable reduction in tender point counts and overall pain intensity in patients receiving active radiant therapy. Photobiomodulation provides a localized, cellular-level intervention that functions as a non-pharmacological analog to traditional analgesics. Thermal modalities, such as whole-body cryotherapy, utilize extreme temperature changes to trigger systemic biological responses. Unlike local cold packs, exposing the entire body to sub-zero temperatures initiates a rapid shock response. Randomized controlled trials have identified measurable changes in a patient's serological profile following a series of cryotherapy sessions. These sessions are associated with distinct shifts in cytokine levels, specifically modulating the inflammatory markers interleukin 1, 6, and 10. This application of extreme thermal energy induces measurable systemic anti-inflammatory cascades that correlate with reduced disease activity. Viewed collectively, these energy vectors form a systematic toolkit for clinical pain management. We can now identify which specific branches of the taxonomy are supported by the most rigorous, sham-controlled evidence. Current research provides strong support for the clinical efficacy of TENS, TDCS, RTMS, and low-level laser therapy in treating fibromyalgia-related pain. It is important to note that these modalities are not intended to serve as standalone, passive treatments. Their primary role is to support the EULAR foundation of care, working in conjunction with active mechanical loading and aerobic conditioning. These interventions act as catalysts, modulating the neurobiology of the patient to make evidence-based exercise protocols physically possible. Clinicians can optimize these outcomes by matching the specific energy vector to the patient's primary pathophysiology. Peripheral tools like TENS and local photobiomodulation are indicated when movement-evoked pain is the primary barrier to rehabilitation. In cases of profound, therapy-resistant central sensitization, the evidence supports an escalation to central brain stimulation through RTMS or TDCS. Modern physical medicine integrates these various forms of applied physics to address the specific biological markers of the disease. This strategic use of electricity, magnetism, and light allows clinicians to systematically modulate the neurobiology of fibromyalgia pain.